Good evening, everyone. My name is Linda Chandler Jacobs, and I would like to thank everyone for sharing this part of your evening to find out more about the clinical manifestations of sickle cell disease and the dental patient. This course is usually a three-part course. Each part is about 3 hours in presentation. So I had to take this 9-hour course and condense it down into 45 minutes. So I hope that you'll find this information very, very informative for you. I am a registered dental hygienist. I have a degree in biology and also a PhD in clinical hypnotherapy. And I have been a hygienist for at least 50 years now, and sickle cell has been my passion. So let's get this going and dive into it because we don't have a lot of time and it's a lot of information to cover. So, exactly what is sickle cell disease? Now, sickle cell was first recognized in the United States in 1910, but believe it or not, it's been around for over 5,000 years. My mother had a moderate form of the disease, and I and my children both possess the trait, and we have what's called a dominant trait. However, what concerns me the most in both medical and dental offices is the health history questionnaire. The questionnaire never asked about sickle cell disease as a standalone. It usually will ask about a blood disorder. However, the way the questionnaire is worded, it eludes the sickle cell patient from answering yes to the blood disorder question because society has sickle cell as a disease, and it is actually a blood disorder. But your chief concern as a dental professional, when you have a new patient or even an existing patient of African descent, of Spanish descent, Mexican descent, or even Asian descent, should be, does this patient have sickle cell disease or even possess the sickle cell trait? Because believe it or not, most of the time, they don't even know. However, this little known fact, when it comes to dental treatments such as perio, ortho, endo, and even implants, can make the difference in the success or failure of your treatment plan. You, as a clinician, may have done all the right procedures and you may have done all the right things. However, you didn't know, and in a lot of cases, the patient didn't know that they have sickle cell disease. Hopefully, this information will help you to recognize more about the disease and familiarize you with some of the things that you need to know about sickle cell disease. So, what we're going to do is we're going to look at a brief video. And this video is by a very good friend of mine named Dr. Amber Yakes. Dr. Amber Yakes is a hematologist, and she is one of the leading hematologists in sickle cell disease. And she has created a lot of videos to help educate the public on what sickle cell disease is all about. So let's just watch this real quick video on sickle cell disease, and then we'll get back to it.
What shape are your cells? Squishy cylinders? Jagged zigzags? You probably don't think much about the bodies of these building blocks, but at the microscopic level, small changes can have huge consequences. And while some adaptations change these shapes for the better, others can spark a cascade of debilitating complications. This is the story of sickle cell disease. Sickle cell disease affects the red blood cells, which transport oxygen from the lungs to all the tissues in the body. To perform this vital task, red blood cells are filled with hemoglobin proteins to carry oxygen molecules. These proteins float independently inside the red blood cell's pliable donut-like shape, keeping the cells flexible enough to accommodate even the tiniest of blood vessels. But in sickle cell disease, a single genetic mutation alters the structure of hemoglobin. After releasing oxygen to tissues, these mutated proteins lock together into rigid rows. Rods of hemoglobin cause the cell to deform into a long, pointed sickle. These red blood cells are harder and stickier and no longer flow smoothly through the blood vessels. Sickled cells snag and pile up, sometimes blocking the vessel completely. This keeps oxygen from reaching a variety of cells, causing the wide range of symptoms experienced by people with sickle cell disease. Starting when they're less than a year old, patients suffer from repeated episodes of stabbing pain in oxygen-starved tissues. The location of the clogged vessel determines the specific symptoms experienced. A blockage in the spleen, part of the immune system, puts patients at risk for dangerous infections. A pileup in the lungs can produce fevers and difficulty breathing. A clog near the eye can cause vision problems and retinal detachment. And if the obstructed vessels supply the brain, the patient could even suffer a stroke. Worse still, sickled red blood cells also don't survive very long, just 10 or 20 days, versus a healthy cell's 4 months. This short lifespan means that patients live with a constantly depleted supply of red blood cells, a condition called sickle cell anemia. Perhaps what's most surprising about this malignant mutation is that it originally evolved as a beneficial adaptation. Researchers have been able to trace the origins of the sickle cell mutation to regions historically ravaged by a tropical disease called malaria. Spread by a parasite found in local mosquitoes, malaria uses red blood cells as incubators to spread quickly and lethally through the bloodstream. However, the same structural changes that turn red blood cells into roadblocks also make them more resistant to malaria. And if a child inherits a copy of the mutation from only one parent, there will be just enough abnormal hemoglobin to make life difficult for the malaria parasite, while most of their red blood cells retain their normal shape and function. In regions rife with this parasite, sickle cell mutation offered a serious evolutionary advantage. But as the adaptation flourished, it became clear that inheriting the mutation from both parents resulted in sickle cell anemia. Today, most people with sickle cell disease can trace their ancestry to a country where malaria is endemic. And this mutation still plays a key role in Africa, where more than 90% of malaria infections occur worldwide. Fortunately, as this adaptation thrives, our treatment for sickle cell continues to improve. For years, hydroxyurea was the only medication available to reduce the amount of sickling, blunting symptoms, and increasing life expectancy. Bone marrow transplantations offer a curative measure, but these procedures are complicated and often inaccessible. But promising new medications are intervening in novel ways, like keeping oxygen bonded to hemoglobin to prevent sickling, or reducing the stickiness of sickled cells. And the ability to edit DNA has raised the possibility of enabling stem cells to produce normal hemoglobin. As these tools become available in the areas most affected by malaria and sickle cell disease, we can improve the quality of life for more patients with this adverse adaptation.
So as you can see, Dr. Amber Yates has given us a very good definition of sickle cell disease. So let's keep going. Now, in order to really understand sickle cell disease, we'd have to really go back to Biology 101 and review the hemoglobin and how it functions. Now, I have the slide up here, and this shows a artery and a vein, and it shows basically how this functions. Now, remember, red blood cells contain an iron-rich protein called hemoglobin. The hemoglobin molecules absorb oxygen molecules in the lungs, circulates them to all the different tissues in the body. Hemoglobin carries 97% of the oxygen that is transported by the blood from the lungs. The iron contained in the hemoglobin is what gives blood a red color. Now, the main function of hemoglobin is to transport oxygen from the lungs to the tissue and then transport the carbon dioxide back to the lungs to be exhaled. Now, in this next slide, I'm going to show you a cross-section of both. At the top, you have what we call a normal red blood cell. And as you can see here at the top, these are round donut shell blood cells, and they are flowing very freely. But as Dr. Amber Yates said in the video, when you have a sickle cell, it causes a blockage. And when I'm explaining this in our long lectures, I usually like to think of that blockage, think of it as a big traffic jam, a big wreck, and everything is piled up. And everything behind the pileup, that's where the blood stops. Everything has to pile up. No blood is getting there. So all that tissue is being damaged for lack of oxygen and blood. So this is what we call a vaso-occlusal crisis, or in layman's language, is called a sickle cell crisis. Once you have this sickle cell crisis, that patient is in extreme pain. And generally, most crises, they end up in the hospital for anywhere from 12 to 14 days. They have to have a series of blood transfusions because a lot of the tissue is deprived of the oxygen, and they have to get that oxygenation back in there. Now, when they are in this type of pain, they're on a lot of drugs. And what happens with the sickle cell patient is because they have to take so many pain medication, they are labeled what we call drug seekers. They're looking for the drugs for a high, but actually with the sickle cell patient, they need those drugs to relieve the pain. And with a sickle cell patient, and we call those patients warriors, they have a hard time. We found out that a lot of the dental professionals didn't know a lot about sickle cell disease, but what was amazing is how many medical professionals know very little about sickle cell disease. So that when these patients show up at an emergency room or a trauma room and they look at their medical record and they see all these medication they've taken for pain, they are labeled as drug seekers, and all they're trying to do is get out of pain. I can show you some other videos that we have and where people are going through crisis and they're in pain. The worst thing that you can see is a child, a little infant that's just born and they have full-fledged sickle cell disease and they're in so much pain and all they do is cry. But one of the things that really hurts our sickle cell warriors is the fact that so many people know so little about this disease that they are misunderstood, they're not recognized, and sickle cell disease is definitely under-researched, and there's not a lot going on as far as the research for sickle cell disease. And as someone that studies sickle cell disease now for close to 50 years, I learn something new every day about what sickle cell disease is all about. So when these cells get trapped in the blood vessels, they do harm the blood flow. And this causes, like I said, intense pain anywhere in the body where it attacks. And this, again, is what's called the sickle cell crisis. Now, what I'm going to show you next is a reenactment of what actually happens when a patient goes to an emergency room. And this happens with a lot of the patients that we treat because it's hard to find areas or hospitals that really know a lot about sickle cell disease so that they can help our sickle cell patients. And this is the trouble. This is the ordeal they go through every time they go somewhere that do not know about their disease. Now, this is what's called a sickle cell crisis.
It's okay, baby. Go ahead. Move your car right away because you're under this parking. Show your face, your car right away.
Okay, yeah, I know. Hey, just go inside. I'll be right in there, okay?
The computers are down.
I'll check it out.
Help! I need a doc. I am sick.
You're sick.
No. Help! Somebody help me, please.
Looks like we have another one. What's going on out here?
I need some help.
All right, let me give you a hand. Down over here. Have you been...
What have you got, John?
I don't know, doctor. This young man was out here screaming. Thought he was with a gunshot.
I'm Dr. Stewart. What's your name, son?
Ned Gwynn.
I think I've seen him here before.
What's the problem, Mr. Gwen?
It hurts.
Where does it hurt?
All over.
You're holding your stomach. Does your stomach hurt?
Yes. Arms, legs. I need Demerol for the pain.
Demerol.
I should have known.
I have sickle cell.
Sickle cell?
You have sickle cell?
Do you have your sickle cell form?
Forms, cards.
Mr. Gwen, if you have sickle cell, we'll take care of you.
This is a member card. Where's your sickle cell form?
I don't know.
I don't want to give him any Demerol.
I'm gonna take him in the back and give him 5 milligrams of morphine.
Go ahead.
No, don't take me in the back. I just need Demerol.
But they come through here all the time dressed just like him. Either looking for drugs or wanting us to take a bullet out.
But go ahead and check his card out.
Can't. Computer's down.
Please, give me something for the pain.
Should I call detox?
Mr. Gwen, I want to help you, but we need to check your card, and our computers are down.
Just give me the Demerol.
Look, we can't just give out drugs to anyone who walks in.
Give me the goddamn Demerol.
Take it easy. It's okay. Hey. I'm getting security.
Mr. Gwen, have you ever gone through a detox?
No.
We can begin the process now.
Are you all right?
Are you related to Mr. Gwen?
I'm his girlfriend.
Your boyfriend needs some help.
He just needs some Demerol.
Yes, I know.
So give him some.
It's not that simple.
What's the matter with you? Can't you see he's in pain? Give him the Demerol.
He says he has sickle cell.
He does. That's why he needs the Demerol.
Well, where's his sickle cell form?
In his wallet. He had his form.
He gave us a member card, but our computers are down. When they come back up, I'll be able to check his card.
Dr. Stewart, we need you in trauma 1.
Please, just give him the Demerol this one time.
I need to check his card.
He does have sickle cell, honest.
Look, I'm sorry, but we have a policy about giving out drugs.
All right, he's a drug addict then. Is that what you want to hear? Now give him something for the pain.
Has Ned ever gone through detox?
Is it because he's black?
Black?
Oh, he's young, black. He must be on drugs.
I never said that.
That's what you were thinking.
Look, I have no proof that your boyfriend has sickle cell. I don't care what color he is.
Come on. It's all right. I'll take care of you.
Can you please wait? Look, I'm sorry. I'd really like to help.
Dr. Stewart, security's here.
Dr. Stewart, we need you in trauma 1 now.
I'm coming.
And ironically, this is what they go through every time they go to a place, a hospital, or even like a dental office that do not understand sickle cell disease. And one of the things that was most traumatic for myself and Dr. Morency, who is my partner with this, is just so many dentists that do not know anything about sickle cell disease, and especially when we go through some of the dental considerations when you're dealing with someone with sickle cell disease. But let's look at this one slide, and it shows the statistics. And as Dr. Amber Yates said, it affects everybody. You know, people of African ancestry make up 90% of the population of the sickle cell disease in the United States. However, sickle cell disease also affects people of Hispanic, South Asian, South European, Middle Eastern. A lot of people are affected by sickle cell disease. But one of the things that I hold strong in my conviction is we must not allow sickle cell disease to be pigeonholed as a Black disease, when in fact it's the most prevalent genetic blood disorder in the world. Now, when we look at the chart, it tells you that 1 in every 365 African Americans born in the United States of America are born with sickle cell disease. However, believe it or not, there is a very large Hispanic population with sickle cell disease, and about 1 in every 13 African Americans is born with the sickle cell trait. So that makes sickle cell is more than 3 times as common as other genetic disorders in the United States. Now, one of the amazing things about sickle cell disease is that so many people do not even know their sickle cell trait, that they don't know their sickle cell status. They don't know if they have the disease, or they don't even know if they have their trait. Now, back in 1974, Dr. Charles Whitten, who was a leading hematologist at that time, fought and had legislation passed that every baby of color should be tested for sickle cell disease. So in 1975, only 1 state was testing for sickle cell disease. 5 years later, we only had 3 states testing for sickle cell disease. 10 years later, we had 29 states testing newborn babies at birth. It wasn't until 2006 where all 50 states were actually testing for sickle cell disease. So as you can see, we have 32 years. We have 32 years of generations of people who do not know their sickle cell status. So when you have people that come into your dental office that have unexplained kidney problems, they've had to have hip replacements, they've had to have their spleens removed, they've had bladder stones and different things like that. If you ask them if if they know their sickle cell status, they will tell you no. And then sometimes we will tell them maybe you need to go be checked out to see if you have sickle cell disease or the sickle cell trait. Because all of these things that I have just mentioned, and also that Dr. Amber Yates mentioned, are what we call cousins to sickle cell disease. So you may have someone in your practice that have had some dental work that failed, and they didn't know that they had sickle cell disease or the sickle cell trait. So there's a lot of information out there that we all, as clinicians, need to know about. But before we could talk just on and on about sickle cell disease and some of the medications that they use. There's so many facets of this disease that makes it very, very interesting. But because of the time limitation, we're going to just go in and jump into what I call the dental considerations of treating patients with sickle cell disease. Now, I have studied this for years, and like I said, I've had several patients that I've actually found out just through their dental x-rays and just looking at various parts of their treatment plan that we've actually been able to diagnose or have them to go to the hematologist and be further checked. But we can look at a lot of things just dentally to tell if people have sickle cell disease or the sickle cell trait. Now, we can't tell if they have the disease or the trait, but we have enough in their x-rays and just different parts of their dental anatomy that tells us that, hey, you need to go and be checked out to see if you have sickle cell disease or the sickle cell trait. Now, let's look at this Panorex. Now, this is just a normal Panorex, and we see them every day in the office. And now I'm just going to enlarge it. As you can tell, I want you to look at the bone structure in this Panorex. All the bone structure looks nice and white. And one of the things that we always look for when we take a Panorex and we take our 18 series of periapicals and stuff like that, we look at the trabecular pattern of the bone. Now, there's a whole different lecture that we give about that trabecular pattern of the bone. But as you can see, this is a normal person. This is a person that doesn't have sickle cell. They have nice bone height. They have nice bone length. Everything looks nice on them. But if you look at the next Panorex, this Panorex is a person that has sickle cell disease. Now, look at the trabecular changes. I'm going to enlarge this so you can look at it. Look at the radiolucencies down here. There's literally no bone there. And if you look in between the teeth, it's very little bone. Now, with a patient like this, with this very little bone, an extraction is the last thing that most dentists or like Dr. Morency will do. We will try to save a tooth. We'll do everything we can except extract. Now, I've seen some dentists that they will try to extract a tooth in a person with sickle cell, full-blown sickle cell disease, and take part of the jaw with it. They'll take the bone with it because everything, sometimes it's ankylosed, sometimes it's locked into that tooth. So when we extract the tooth in our office, Dr. Morency will take that tooth and he'll basically dissect it and take it out very gingerly so as to not damage the bone, because we already know that they don't have enough oxygen in that bone to actually recuperate. We also, when we are going to do any type of extraction or even a deep scale, we also have to correlate with the hematologist so that we can make sure that their hemoglobin count is right. We have to look at the precautions that the hematologist wants us to take, because some of these patients are on hydroxyurea, which is a cancer drug. A lot of them were on a drug by Pfizer called Oxbryta, but they took the Oxbryta off the market. But Oxbryta would actually help the red blood cell to stay oxygenated. And this made it a lot easier. Now, they took Oxbryta off the market in the United States we actually didn't have a lot of problems here in the United States, but in Africa and some of the other countries, they had 49 deaths because of the oxbryta. So Pfizer chose to pull oxbryta off the they pulled it off the menu so that the patients couldn't have it, so they had to go back to hydroxyurea. So that left a very big void for us because we had to literally stop treating the sickle cell patients because we had to see what their hematologist was going to do if they were going to put them back on hydroxyurea or different ones. Now, we all know that hydroxyurea is a cancer drug, but fortunately for the patient with sickle cell disease, they don't get that same dosage that a cancer patient gets. So we are allowed to do a little bit more treating with hydroxyurea than we would with a cancer patient. If you recall, when you have a cancer patient with hydroxyurea, we have to take that patient off hydroxyurea for 7 to 14 days before we can really go in and do anything extravagant in their mouth. But continuing to look on at this x-ray, this Panorex, another thing that we see a lot, look at these lower anteriors and look how short that root surface is. Now, with this radiolucency here and no bone, these teeth are not getting a lot of oxygen. And a lot of times what we'll find is we will also find that the nerve of the tooth will start to calcify. So this is another thing that we will look for. And if you look very closely right down here along the edges, you can see the nerve of these teeth have already started to calcify and they're starting to resort. So we'll see that a lot, especially if you have a patient in ortho and they move the teeth too quickly. We're going to talk about ortho a little bit further in this presentation. But as you can see, if you have someone that presents with a Panorex like this, you should really take heed to go a step further to start asking a lot of questions, you know. So this is part of what we look for when we're looking at it. Now, when we look at a regular radiographic finding, what we're looking at is the trabecular pattern. Now, if you remember in that Panorex, you had the trabecular pattern look like bunch of spider webs all together. And, you know, it was just all over the place and it had very intricate designs and everything. But with a person with sickle cell disease or even the sickle cell trait, they have what we call the step ladder pattern. Now, 50 years ago, when I first started doing my research on sickle cell disease, I was very blessed to have a hematologist named Dr. Clarence Higgins, and he was a leading sickle cell hematologist here in the Houston area, and he was also my children's pediatric dentist. Now, 50 years ago, they tested for sickle cell very differently. They would do a blood smear. And when they would do the blood smear, they would look at the cells. And if they didn't see any sickle cells, that person was deemed to be normal. But if they would see a couple of sickle cells during this blood smear, they would say that they had the trait, because if they had a lot of sickle cells, they know that they would have the disease and refer that child on to the hematologist. Well, this was what they were doing 50 years ago. Now they do a DNA test. Now, 50 years ago, my son is now 56 years old. 50 years ago, when they tested him, they said that he did not have the trait. And of course, I didn't feel like I had the trait either. My mother, who was born in 1912, she would be about 113 years old if she was still alive. She was born in 1912. Remember, I told you sickle cell disease was first discovered in the United States in 1910. So my mother was only 2 years old when they discovered it. My mother was 72 years old, and she was 2 days before she died that we found out that she had full-blown sickle cell disease. So that meant that generally the children or the offsprings would either have the trait or they may have the full-blown sickle cell disease. Later, we did find out that I had a brother who died at 37 who had he would be like 80-something years old if he was still alive. He had all the symptoms of sickle cell disease, but we knew nothing of sickle cell disease. He died before my mother died. My mother she was having crisis all her life. All we knew is that she would get really, really sick and a lot of pain. And then about 10 or 12 or 14 days later, she would start feeling better. And when we took her into the hospital for that final time, she could not walk. She had had a sickle cell crisis on her spine. They did all the tests. They could not find bacterial meningitis, spinal meningitis. They couldn't find viral meningitis. Her spinal fluid was completely clear. It was a sickle cell crisis that hit her spine. She could not walk. She couldn't move her legs. But in 10 to 12 days, she could move her legs again. Then she had another crisis, but this time it hit her heart. So when they went in and did all of the a test on her heart, the doctor looked at us and he said, "Where did your mother get such a bad heart?" We didn't even know she had a heart problem. That's when they started looking at the blood and they found out that my mother had full-fledged sickle cell anemia. And this was in 1985. So this really intensified my knowledge of sickle cell disease, and it really helped me to start really looking into what sickle cell disease was all about. So like I was telling you earlier, that what we would look at, we used to call this the H pattern, but you can see they call it the stepladder pattern. And if you look at how this trabecular formation is, it looks like a ladder. Look at that. That looks like a ladder, and this looks like a ladder. Now, when you get a patient where the teeth have been extracted, then it looks like a ladder that's been stretched out, so to speak. And this next slide, look at this. You can see they have very little trabecular pattern down here, and look at the stepladder pattern. It's like it's stretched out, especially in between this molar. It's really, really stretched out. So this patient, if you see somebody like this and this trabecular pattern is off like this, the first thing that I do is I'll turn and ask that patient, have you ever been tested for sickle cell disease to see if you have sickle cell disease or the sickle cell trait? Now, I did have an actual true story where I had a young lady, she was about 24 years old, and she was about to be married. And she was a new patient to the practice. And we had taken the Panorex, and we had taken the 18 periapicals, and the horror on my face when I saw her trabecular pattern. And she looked at me and she said, "Is there something wrong?" And she said, "Do I have a lot of cavities?" I said, "No, you don't have any cavities, but I'm looking at your bone structure." I said, "Have you ever been tested for sickle cell disease or the sickle cell trait?" This lady's eyes got very, very wide. She said, "No, but I'm about to be married and my fiance has the trait. I need to know." And I said, "Please go get tested." She found out that she had the sickle cell trait also. Now, if both parties have the trait, you have a 25% chance that your child will have the disease. You have a 50% chance it'll have the trait, and you have a 25% chance that it's going to be normal. Now, the old wise tale was that the first child would have the disease, the second child would have the trait, and the third child would be normal. But now, since we know more about the DNA structure of sickle cell disease, every time you have a child, it's like a roll of the dice. It's the genetic roll of the dice. So you can't necessarily go by that. They have gotten so good with this now, so they can actually take the sperm from the male and they can take a fertilized egg from the female and they can put them together in a petri dish and let them form. And they can literally take the eggs and they can tell if that embryo has the trait, that one is normal, or that one has the disease. And this is a very expensive process, but you can do that. And then, of course, they're going to implant 2 or 3 of the embryos in there. So if they all take, instead of getting 1 baby, you might get 2 or 3. But they do have ways of getting around that. But a lot of times you do need genetic counseling if you do marry somebody with the trait. And, if you both have the trait and you need to know what type. Sickle cell disease is just like a snowflake. Dr. Witten's daughter, Dr. Wanda Witten, she does excellent presentations on sickle cell disease. And you can have 2 people with sickle cell SS, where you have two recessive S's, this is full-blown sickle cell anemia, and their symptoms can be completely different. And this is the amazing thing about sickle cell disease. I have a nephew who's 39 years old. He has full-blown sickle cell disease, and he's never suffered a sickle cell crisis. Why? Because he still has his fetal red blood cells being produced. So he has rich oxygenated blood, but these are fetal red blood cells, and he's constantly in production of fetal red blood cells, but this keeps him out of a crisis. Of course, he has to take all the precautions that people do take when they have sickle cell disease. Now, let's go to our other slide, and this is another thing that we look at when we have people with sickle cell disease, and this is pulp necrosis. Now, this is very interesting, especially for you guys, if you have a patient that comes in and they have a bad toothache, and you take the X-ray, you take the periapical, and they have all the symptoms of a dying nerve. Well, with a sickle cell patient, this can be a sickle cell crisis around the teeth. And this happens with both the sickle cell patient or the patient that has the trait. I have that problem around my teeth. Sometimes my teeth hurt. Now, you got to remember that when you do have the sickle cell trait, they used to say that you could live a normal life, but we're finding out a lot of things about the sickle cell trait that is not really normal. And one of the things that you have to remember, even when you have the trait, you have sickle cells floating around in your bloodstream. And what I found out with myself having the sickle cell trait, I'll have pain in my arms or in my legs or in my teeth. And what I generally do is I'll take a vasodilator, like an aspirin or something, that relieves the pain. It dilates the artery so that that sickle cell can pass through. Because remember that arteries and blood vessels are very, very small. But in this, you have the pulp necrosis. Remember, I was telling you earlier that that pulp will calcify. I have a couple of teeth that my pulp is calcified, but I'm not having any problems. So a lot of times a sickle cell patient, or if they don't even know if they have sickle cell disease or the sickle cell trait, they show up, they have a toothache. You can't pinpoint why they're having that toothache. You do pulp, you test the pulp, you test the occlusion, you do everything, but they're still in excruciating pain. One of the gentlemen that we have as our poster guy for our Potter Smile, which is our nonprofit organization, this gentleman went into the hospital in crisis. They thought, the medical doctors felt like his teeth was giving him, putting him in the sickle cell crisis. They pulled 21 of his teeth at one setting and still did not get him out of the crisis. He had 6 teeth left. Later, he came to us. We started treating him. We stabilized all of the 6 teeth because we completely restored his mouth with the 6 teeth. Later, before we had completed the restoration, he went into another crisis, and they thought that it was his teeth again. And so they called me. Methodist Hospital calls me at 11:30 at night, and he is crying. And he said, "Miss Jacobs, please tell these people there's nothing wrong with my teeth. They think my teeth is causing this crisis, and they want to pull my last 6 teeth." So I had to tell the lady who we were, what we did, and that there was nothing wrong with those teeth, and that they needed to look elsewhere, or even if the teeth was hurting, the sickle cell crisis would pass, not to pull the teeth because it wasn't going to eliminate the crisis. So, of course, he kept those teeth, and we were able to reconstruct his whole mouth with the 6 teeth. Now, when we reconstructed his whole mouth, Dr. Morency did I think he called it a long spread bridge on the top teeth, and then we did a valplast on the bottom because he couldn't have the metal frame partial down there because the metal would just kind of work on that soft bone. But we were able to reconstruct his whole mouth. But he had a lot of the same thing. We had to go in and do a couple of the teeth, had to have root canals on them because they were infected. They were truly infected. But, he did have one that did have the calcification of the nerve. So these are some of the things that we have to look at, especially when you start looking at ortho. Now, on our next slide, we're going to talk about periodontal disease. Hold on, let me get it. Okay. With periodontal disease, it has been reported that a periodontal infection that is severe enough can precipitate a sickle cell crisis. This actually happened with one of our patients. This lady, I know we always say a class 3 and a class 4 SRP. This lady was a class 8. Her mouth was so infected until she had pus around the teeth. The teeth were moving. So what we were trying to do with her was just give her an SRP so we could stabilize her to see how many teeth we could save so that we could build on those 2 teeth. Well, every time we tried to get her in to do an SRP, she would always go into a crisis. Finally, when she came in, we had her scheduled to come in to start the sickle cell crisis. We had to start the SRP. We had set everything up with the hematologist and everything. She went into a crisis. And she called me the next morning. She said, I'm in the hospital. They're telling me I have a severe infection. They're looking for the infection, but they can't find the infection nowhere. And this lady, she's deceased now, was named Yvonne. And I said, Yvonne, tell the medical doctors that you have full-blown chronic severe periodontal disease. You have pus all around those teeth. That could be causing your crisis. So she told them that. They pulled all her teeth, which made it easier on us because they did it on the medical side because they gave her a blood transfusion and everything she needed. So we did not have to deal with pulling her teeth. They pulled them all in one setting. And then once she healed, we gave her dentures. So this will happen. And a periodontal infection that is severe enough will precipitate a sickle cell crisis. Now, look at this. This is an actual sickle cell patient. You have the Panorex, and I'm going to enlarge that Panorex for you. You can see the radiolucencies here around the bottom, and look at the shortening here, and look at the amount of calculus underneath the gums. And here, in between these molars, you can see that H pattern. I still call it the H pattern. You can still see that stepladder pattern. You can see all of this, and you can see the narrowing of those roots. And look here on these lower anteriors, you can see how those roots are starting to resorb. Look up here, and he has a lot of horizontal bone loss here. He has an infrabony pocket, and look around his 3rd molar. It has what we appear to be an abscess. Now, in some of our sickle cell patients, we'll see this 3rd molar laying here, and it's completely abscessed. And then we'll have to go in and we'll have to, now, of course, we don't do it. We send them to an oral surgeon that is very, very knowledgeable about sickle cell disease. And we had to send this one patient there, and he had to lose the 3rd molar and the 2nd molar because they had to remove it just to get to this to remove that cyst. Thank God it was a benign cyst. It wasn't anything cancerous. But as you can tell, just looking at this Panorex, that he has these infrabony pockets. He has a lot of tartar. With a patient like this, what we would do is we would do the SRPs, but we would only do one quadrant at a time because we definitely want this patient to feel comfortable in the chair, and we do not want to precipitate a crisis. Now, if you look over here at the actual mouth, look at this. You can see the exudate around these lower anteriors. Look up here how we have the recession here. All of this, look at the rolling of the gums. Now, this patient doesn't have a big diastema, but one of the things that we found out that a lot of times if you see a patient with a diastema or space in between those 2 front teeth, the first thing I'll do is ask them, have you been tested to see if you have sickle cell trait or sickle cell disease? 80 to 90% of the time, these people do not know their sickle cell status. But as you can tell, there's a lot of infection, there's a lot of recession here, a lot of root exposure, and this patient is in chronic pain because of that root exposure. Now, one of the things that I do when we do these deep scales, I don't know if I'm allowed to mention a product, but Voco has an excellent fluoride treatment that I put on those roots to help neutralize, to help desensitize those roots. But I only do 1 quad at a time so that that patient doesn't have a high anxiety level, because their anxiety can actually throw them into a crisis. And we take small step sizes. We give them oxygen, when we're treating them. So we try to keep them oxygenated as much as we can. So let me move right along because I'm running out of a little time here. Now, antibiotics. Antibiotics are always highly recommended for anything like deep scales, if we're going to extract a tooth, or anytime we're working in the mouth, because that's a heavy bacteria load being introduced into that patient's bloodstream. So we will coordinate with a hematologist because a lot of times the sickle cell patient is already on antibiotics. So a lot of stuff has to go on. We have a lot of dialect going on between the hematologist and the dentist, and well, there's a lot going on. Even up to the day that we treat them, we may have that hematologist on the phone trying to find out how they want us to handle this, because the last thing that we want to do is to trigger a sickle cell crisis. Now, periodontal charting is very essential because what we found with most people that do have sickle cell disease, they will generally have a 6 millimeter pocket to the distal of their first molars. And of course, the first molars are the first ones to come out. So they will have that. And I've actually been challenged. I was temping at a dental office one time, and we had our morning huddle, and the doctor said that she had this patient coming in, and she always had the 6 millimeter pocket, and they've scaled it. They've done everything that they can. Sometimes she has it, and sometimes she don't. I asked her, I said, is this patient African American? And she said, yes. And I said, well, does this patient have sickle cell disease or the sickle cell trait? Of course, I looked at the health history, and it didn't show that. She said, well, I don't know. Lo and behold, long story short, the lady came in, and she had a 6 millimeter pocket. And she told the doctor, she said, I've done everything you want. I can't understand why I have this pocket. I floss, I use my water pick, everything. So the doctor looked at me and she said, well, Linda seems to have this theory that you have this 6 millimeter pocket on and off because you either have sickle cell disease or the sickle cell trait. That patient put her both hands on the side of that chair and she looked at that doctor and she said, Dr. So-and-so, I told you I had sickle cell disease. Needless to say, I was never asked back to that office because I actually kind of knew something that she did not know. But we always, again, put our patients on the antibiotics. Now, the dental implants is something entirely different. Dental implants depend heavily on a patient's body to be able to heal. The body heals bone around that dental implant. And, as you know, with an implant, the new bone binds around the implant to ensure stability. But if the body can't heal the bone, then it can't properly incorporate with the dental implant. Now, I had a sister-in-law who has the sickle cell trait. She had a tooth extracted, and she decided she wanted an implant. She went in, they did the implant, and you could actually take an Explorer and just put it on the top of that post and just move it around. It stayed infected. They put her on antibiotics. It could not control the infection. So they pulled the implant off, put some more bone in there, closed it up, and waited about 6 months, and they went back in and did another implant. The same thing happened. So she came to me desperate. She said, why is my implant not holding? I said, well, it could be a number of things. I said, you have high blood pressure. I said, and then you're also pre-diabetic. And she got mad about that. She said, what makes you think I'm pre-diabetic? Because she was 30 pounds overweight. That's usually pre-diabetic. And then it dawned on me. I said, wait a minute, did you tell that doctor that you had the sickle cell trait? She said, no, I didn't think it was important. Well, it was important because it ended up that she did not have the bone density to hold that implant. And he did not send her out to have bone density checked or anything like that. This was about 15 years ago. So she ended up having a 3-unit bridge. So see, these are some of the things that you do need to know. And if you look at this implant right here, this is a sickle cell patient with an implant. Look at that tissue. That tissue doesn't look good around that implant. And this one did not hold up. That one did fail. And we ended up doing a 3-unit bridge around that. But one of the things that you have to look at with this is you have to always make sure that these patients are a good candidate for an implant. So a good candidate for an implant is usually the oral surgeon who does it, because a lot of times with a sickle cell patient, we'll send it to an oral surgeon because they have to have what's called a prophylactic blood transfusion, and that's a blood transfusion that they have just for the procedure. And sometimes that oral surgeon may choose to use a smooth post instead of the screw type, device because it doesn't damage as much of the tissue and the bone, and you have a better healing. Also, the sickle cell patient, like I said, may need to undergo a blood transfusion before or after the surgery to reduce the concentration of the sickle cells in the blood. Then it is a common practice to reduce the surgical risk. This is a common practice to reduce that surgical risk and is highly effective in reducing tissue and blood damage. So a lot of times we will have them to have a blood transfusion before we do a lot of things. And if the patient needs a blood transfusion, then the implant procedure may be scheduled in the hospital setting. Of course, now when you do put it in that hospital setting, it increases the cost. Now, with orthodontic treatment, that's entirely different. Now, orthodontic treatment for the sickle cell patient is strictly elective, and a lot of times it's not good for the patient to have the orthodontics because remember, when you have ortho, you have to dissolve the bone in front of the tooth and move it forward, and you depend upon that patient to develop bone behind that tooth to hold it steady. Well, this doesn't necessarily happen with a sickle cell patient. And so what will happen is, especially around the lower anteriors, that bone is very thin. From like cuspid to cuspid, that's very thin bone. And a lot of the patients that have had full-blown sickle cell disease, they want to have their teeth straight. And they said, well, I'm going to the orthodontist. And I'll ask them, does this orthodontist know that you have sickle cell disease? Yes, he said it didn't matter because he was going to move the teeth. Well, in all of these situations, most of them we had to go back and do a 6-unit bridge across the top and across the bottom because that bone was so thin. And then the nerve died and the tooth resorbed, and they were like little chiclets in their mouth. So a lot of times, it's not good. Now, with Invisalign, we found that we've had a lot of success with Invisalign because we can slow down the process of moving the teeth. However, sometimes these people have to stay in braces about 3 years, but it moves the tooth a whole lot slower, and it makes a difference when we're trying to do the ortho. Now, another thing is missing teeth, hyperdontia. Now, a lot of times they will genetically be missing teeth, and a lot of times you have these patients come in and they're genetically missing these teeth. So when they're genetically missing these teeth, that's so usually the first thing I ask, okay, you're missing that second bite. Have you ever been tested for sickle cell disease? And they will say no. A lot of times this happens. My granddaughter is missing about 3 or 4 teeth. Now, of course, because her grandmother knows this, she has space maintainers and everything. Now she is in ortho. She has the trait. Her bone density was okay. And the doctor is literally putting very minute chains on that to pull those teeth in place. But if you do have a patient in your chair and they're missing teeth and they don't know their sickle cell status, that's something that you can always ask. In fact, we talked with some doctors. We lectured to the Louisiana Dental Association and the New York Dental Association. And when we finished our lecture, a lot of the dentists came up and they have, diversity in their office. And so this is why we thought it was very, very important. Because of that diversity, they said that they'd had a lot of failures in certain areas. Now they were going to go back and revisit those patients to see if they had sickle cell disease or the sickle cell trait, because they were armed with a little bit more information where they could actually treat these patients. So when you have a sickle cell patient, you do want to pay particular attention, should be given around the bone of the upper and lower anteriors, especially when you're going to be doing ortho. You also want to always look for a necrotic pulp tissue or any pulp that's calcified. This should be noted before you apply any force to those teeth to move them, because they're not going to recuperate because the nerve is already dead or the nerve is already calcified. So that's something that you have to look at. And if the pulp is calcified or necrotic, the roots of the tooth will resorb because the nerve has no nourishment in place to reestablish itself in the bone. So these are some of the things that you have to look at when you have a sickle cell patient. Also, once the affected teeth start resorbing over time, they become mobile. and they have to be removed. So this is another thing that we have to look at. So we look at a lot of things when we're treating those sickle cell patients. We look at the medication. We look at their hemoglobin level. There's a lot of stuff that has to go down. There's a lot of communication between us and the hematologist and the medications they're on. We're constantly learning medications and how they affect the patient and how it will affect dentistry. And then the clinical appointments are always arranged during the chronic phase of the disease. We don't ever bring a patient in that's in a sickle cell crisis. In fact, when we're lecturing, we tell the dentist or the hygienist, if you have a patient that's in a sickle cell crisis, number one, they're not going to be in the chair because they're in too much pain. They're generally in a hospital. And when they're in the hospital, they're there for 12 to 14 days. And generally, in those 12 to 14 days, they do not brush their teeth. And that hurts them immensely. They're in so much pain to the last thing they're thinking about is actually taking care of their teeth. And another thing that really hurts our sickle cell patients is that a lot of them do not have insurance. Now, from 0 to 18 years old, they can have Medicaid. Medicaid does offer them dental benefits, but once they turn 18, this is where they they go down the rabbit hole. And these are the ones that we generally see because they don't have the money or now I can't say all of them aren't broke. They do have money. They have dental insurance and stuff to get a lot of the work done. But a lot of them that was on Medicaid generally don't have the financial access to get a lot of the work done. So they tend to do without. So what we do at the Potter Smile is we offer that level of dentistry. We do as much of the dentistry as we can for free because we get a lot of donations from Henry Schein, Patterson, and they give us a lot of our supplies. Voco, they give us a lot of our supplies so that we can do more work for the sickle cell patient free of charge. We try to do as much of the work free of charge. Of course, the labs can't really give us much of a break, so we do have other methods that we do to raise money to help these sickle cell patients. Finally, elective surgery such as extractions of asymptomatic teeth for orthodontic indications are strongly contraindicated. We usually don't go in and pull those bicuspids and stuff. We try to leave as many teeth in the mouth as we can before we do anything like that. Okay, some doctors recommend the sickle cell patient should be referred to a maxillofacial surgeon who will ask for a complete blood count to evaluate the possibility for treatment. We've had that to happen too. And we didn't get a chance to really cover occlusion in this, but their occlusion tells you a lot. And a sickle cell patient will have different types of occlusion. And that is a whole different lecture. And that's a good lecture that you can take with Dr. Morency because he really understands, how that occlusion and sickle cell do. And again, if the teeth are moved too quickly, they may not recover. Generally, they don't. And I've seen patients who've had ortho, not only those anteriors, but they've actually lost a couple of molars. And it doesn't look very pretty, and they're very unhappy. Now, a lot of times, sickle cell patients that don't know, they think that they can have a full mouth of implants. Well, no, they can't do that. My brother, who has sickle cell trait, did the implants where you have the dentures that snapped in. He is picking out those implants one by one over the years. So that happens like that. So remember that when you're treating a sickle cell patient, the infection states as well as the surgical procedures invariably will require antibiotic coverage. We always cover them with antibiotics, and we also talk with the talk with the hematologist to make sure they're not already on some type of antibiotic, and we correlate with them because they may want to put them on a different type of antibiotic. It's constant conversation between the dental office and the hematologist. We found that prevention is the ideal approach for the treatment with the sickle cell patient, and we try to get them as early as we can. We see them as early as 18 months to start watching that tooth pattern and a whole bunch of stuff that happens in their mouth. And the pediatric practice, the primary goal is to improve and maintain excellent oral health and decrease the possibility of oral infections. And then treatment should never be initiated during a crisis unless it's an emergency situation, and then treatment should be designed only to decrease infection and discomfort, preferably under the supervision of that patient's doctor. Now, that brings us to the end. And just for your information, these are the references. This is just part of the references that I use for this presentation. Like I said, this initial presentation is usually about 3 hours long. I hope I gave some insight to anybody that may have seen some sickle cell patients. And remember that the diversity in your dental practice is not just limited to the African American. We have Hispanics. We have a large white population that do have what's called, they call it hemoglobin S, but the bottom line is it's still sickle cell disease. So, Truong, do we have time for question and answer?
Yeah, go ahead.
Okay, now let me go. Remind me of where I'm supposed to go to look at it.
It'll be under more and Q&A.
Okay, hold on. I don't want to end it. Let's see, more. Oh, here we go. Hold on. Believe it or not, I'm having trouble pulling it up. There we go. More. And Q&A. Okay. All right. Okay, I have one question that says, does insurance pay for sickle cell tests? The medical insurance, some of them will pay for it, but generally it's a blood test, and a lot of people don't. Believe it or not, people don't like needles. And when you do this, you have to ask specifically for a sickle cell test, because a lot of people will say, I've had blood tests all along and nobody has told me this, but they have to test specifically for the hemoglobin S genetic thing when they do that blood test. Then this next question say, every once in a while, I see an African American female with a apical lucencies on health and teeth. Could this be related to sickle cell anemia? It could be, but we'd have to see what they have going on. A lot of times it could just be occlusion, but that's a good question. I would have to, I'll direct that Ben toward Dr. Morency, and I'll ask him what he thinks about that. And then she said, very informative. Why does crisis subside in 10 to 14 days? Okay, Carol asked, why does crisis subside in 10 to 14 days? Generally, in 10 to 14 days, they're in the hospital. They've had a couple of blood transfusions. They've had oxygenated blood put back into their system. Now, they don't just get blood transfusions all the time, because with the blood transfusion, you go into iron overload. And an iron overload can be just as bad, and an iron overload can actually trigger another sickle cell crisis. But generally, if the crisis affects the heart, the spleen, the kidneys, somewhere in the brain, or some of the major major organs, they like to do a blood transfusion immediately to get oxygen to those things. So generally, they're in the hospital. Sometimes they're in the hospital longer. We have one patient that we were getting ready to pull a tooth on, and she thought she was getting ready to have a crisis, so we would not do that. And that was last month, and she's still in the hospital. So it's just according to what their crisis does, how it's affecting them. But there are a lot of tattletale signs that we offer in our main course that helps us to help you to identify a whole lot more with what's going on. Okay, thank you, Angela. She said I delivered a lot of much needed information. Thank you, An. Okay, excellent lectures. Okay, all right. I think I have covered fibromyalgia. You know what? There is some research, Ashley, about that. Now, what we found out is sickle cell is the most understudied and under-researched disorder. I like to call it a disorder because it's not a disease. And a lot of the sickle cell patients will not tell you they have sickle cell disease because people think they're contagious. One of my goals before I close my eyes is to try to get it changed from sickle cell disease to a sickle cell disorder because it's not a disease, it's not contagious. If you touch that person, you're not going to get anything from them. Yeah, and okay, now M says you said 80 to 90% of patients with diastemas don't know whether or not they have sickle cell disease. That's been my experience. I can only speak of my experience. When I'm in the grocery store, I see a young lady or a young man with a diastema, I'll stop them and ask them, have you ever been tested for sickle cell? And I'll tell them why, because we do see that with the diastema. And I know that all of my relatives that have sickle cell disease or the sickle cell trait, the ones that have they all, not all of them, but a lot of them do have the diastema. So that always brings you up to think about it. Hey, I wonder if this person has sickle cell disease or the sickle cell trait. And generally they do. And again, a lot of people do not know, you know, their sickle cell status. And this is one of the reasons that we at the Potter Smile, we are buying a DNA sequencer and we're going to start testing America because we have that large amount of people that don't know their sickle cell status and they need to know it. And one of the things that we found as we have tested people that we go into what we call sickle cell clusters, because if you find a 70-year-old that has full-blown sickle cell disease, he has his children, his grandchildren, and sometimes his great-great-grandchildren. And if they haven't been tested, then they don't know. And we have that generation of people that 32 years, and then if everybody before 1974, I was born in 1953. So I wasn't tested. So from 1953 to 1974, that's 20 years. That's when they started testing. There's another group of people that need to be tested. So it's important that these people know their sickle cell status because it helps you as a dental professional. Because if you know, especially after hearing this small presentation, that they come to you and they say they have sickle cell disease or the sickle cell trait, you're going to approach them very differently. But there's so many people out there that are having problems. Like I said, when I have a patient that has a kidney problem or anything like that, I look at that. So I think I'm out of time. Trong, am I out of time? Am I off the air?
I think we're done with questions. So thank you so much, Linda.
Okay. And thank you all so much for listening. You all have a pleasant evening.